All right, so I'll go ahead and get us started. Hello, everyone. Thank you for joining us this afternoon. My name is Daisha Warren, and I'm the Health Education Specialist for the Prematurity Prevention Initiative at the Partnership for Maternal and Child Health of Northern New Jersey. I would like to welcome you all today as we kick off our August Summer Speaker Series events. Today, the Prematurity Prevention Initiative team will be hosting a discussion on premature birth interventions and resources available, such as 17P and its benefits in preventing a premature birth. Today, our speaker is Christine Ivory, who is the Assistant Director of Public Health Programs at Southern New Jersey Perinatal Cooperative. And then before I begin, I wanted to share that the Prematurity Prevention Initiative, also known as PPI, is a collaborative cross-sectional effort aimed at focusing community engagement on available evidence-based interventions aimed at reducing premature birth rates in New Jersey. The Prematurity Prevention Initiative is under the direction of Family Health Initiatives and is supported by funding by a grant from the Community Health and Wellness Unit of the New Jersey Department of Health. So a few housekeeping rules for today's event. We ask that you please remain muted during today's presentation. If you have any questions, please feel free to add them to the chat. And at the end of today's event, we will have a Q&A portion. And lastly, today's session will be recorded and shared for future use. And without further ado, I'm going to pass it over to Christine to present for today.
Absolutely. Thank you so much, Deja, for that warm welcome and getting us ready and jump started. It's really great to be here for our third annual speaker series for PPI. So I'm really, really glad to see all the faces and all the folks here to join us for this series. So today we're going to be talking about pregnancy and preterm birth as it relates to providers and those that are professionals in the maternal child health space and field. And so I'm going to start to share my screen. All right. Okay. I think we're looking good, Deja. Let me know if we're not. Okay. And so we're talking to providers, we're talking to professionals. And if you are outside of that group, and if you are a community member, if you're a parent, or you might be all of the above, we're super excited once again for you to be here for this conversation as we talk not only about preterm birth, we'll also talk about Black infant and maternal mortality. But I think one of the most important pieces that we'll talk about is some strategies and some takeaways that we can move forward with. So as Deja mentioned in our welcome, my name is Christine Ivory, and I'm the Assistant Director of Public Health Programs at the Southern New Jersey Perinatal Cooperative. And I also oversee one of our really special grants, which is the Prematurity Prevention Initiative, or today you'll also hear me referred as PPI. So without further ado, we'll get started. And as Deja also mentioned, one other thing, if you have any questions, feel free to plug them in the chat as we go, because we will make some space for questions and answers towards the end. So getting started, and Deja just mentioned this in our welcome, so I will not tarry here and stay here too long, but the Prematurity Prevention Initiative is known as PPI, and we're a collaborative cross-sectional effort that's aimed at lowering and reducing the number of preterm births in New Jersey. And so we know in the state of New Jersey that preterm birth, as well as maternal mortality, infant mortality, are all at a state of crisis. In fact, in New Jersey, we're about at 110. So for every 10 births, there are about 1 babies that are born preterm. And so we're trying to lower that number because we know as we lower preterm births, we're also in turn lowering infant mortality. And we want to just see better birth outcomes as we think about pregnancy and birth and beyond for the family at large. So on our agenda today, we have a few great items. The first is an introduction, which we are working our way through right now. The second is racial disparities in maternal child health. So we'll talk about the landscape of maternal child health in New Jersey. We'll talk a little bit about what it looks like in the US, because I see that there are some that joined us outside of New Jersey. So thank you also for joining us, which is wonderful. We'll move forward to preterm birth in New Jersey. So what are the numbers? What is the data like to date? We'll go into prevention and intervention as it relates to preterm birth. And then we'll go into some PPI focuses. So what can PPI offer? What type of goals do we have in mind? What type of strategies, as well as our resources for providers and those in the healthcare field? And we'll end with our call to action. So a few learning objectives as we go through today. The first is we're going to form a deeper understanding of maternal child health with the landscape as it looks like, not only from a state level, but also from a national level. We'll certainly touch on that as well. We'll discuss health disparities as it relates to health equity and racial disparities as well, which is my next point here, which is discussing the impact of racial disparities on maternal child health. We'll review preterm birth prevention and intervention strategies, as I mentioned. So we'll walk away with a few different interventions that we could use for patients and our clients. And then lastly, we'll learn about the available resources for pregnant patients. So some that PPI has and we could offer, but then we'll also talk about some other resources as well that can be accessed nationally. So starting off with our maternal and child health landscape. So really just setting the stage for our conversation today. As I mentioned on our first slide, as we're talking and going through our introduction piece, we know that infant mortality, maternal mortality, as well as preterm birth is at a state of crisis, and not only in New Jersey, but from the whole nation, if we look at that landscape or through that lens. And so we'll definitely take a focus on these first two pictures, as we can see. And I love these little baby pictures in the feet, and they're really beautiful and precious. But one thing I want to bring it back to is the social determinants of health. And what does that mean to our focus as we think about maternal child health, as we think about the whole scope of what it looks like for families, for communities, and how does that impact birth, where we live, where we play, and where we grow, and all those factors around it. So we'll have a larger conversation around that today. So getting into that conversation, as we think about, once again, where we work, where we live, where we play, where we worship, the social determinants of health, we can't talk about the social determinants of health without talking about equity and then talking about disparities that impact equity, right? And so first, let's lay down a couple of ground rules, but just define a couple of terms here. And the first one will be a health disparity. And so a short answer for a health disparity, it is a preventable difference experienced by socially disadvantaged populations. And we know that those populations are systemically disadvantaged. It could be because of their race, because of the color of their skin, their sexual orientation, their ability, and there's so much that we could add to the list there. And those are our disparities, right? But when we think about what we work towards as we're professionals and providers and practitioners in the field, is more or less the health equity piece. And that's when everyone has a fair and just opportunity to be as healthy as possible. And that's what we work towards. And so when we think about equity, we're removing the obstacles of disparity. We're taking away anything that impacts like some discrimination or racism, and we're replacing it with what that person or what that group of people may need. Which brings us to our next slide, which is equity versus equality. And a lot of times when we hear the words equality and equity, we almost think of them as synonymous, right? Which is very unlikely, it's very true, it's not true at all. But what I want to do really quickly is just go over this picture, and pardon me if you saw this picture before, but I can't just go past this point without going through equity and equality. And so when we can look at this left side of the picture here, we see that this is a depiction of equality. I always say I'm in the Philadelphia area, so our team is the Phillies. So let's say that these three folks, they're looking into the Phillies game, or at least they're trying to. And each of them, they are on their one box, right? So we see the person in the blue shirt, he is thriving. He doesn't probably even need this box. He's relatively tall. Person in the middle, he has his box or she has her box, and they're doing just fine on their one box. But what our attention really brings us to is that person on the right-hand side in the purple shirt, as we see that that person has that one box, but they cannot see into in this conversation in the Phillies game at all. Their disposition is down, their shoulders are down. Even if they peek through the cracks, they really can't see. But when we look at the equity side, we see that it's about giving the resources that are needed for that particular person or that particular group. So once again, the person in the blue shirt, they're doing just fine on their own. They do not need a box. Person in the middle just needs one. And now we can see the disposition on the right-hand side again of our last person in the purple shirt. You can see into the game. Hands are up, no longer with the shoulders down or the hands in the pockets. And so this is a funny kind of little picture that we like to pull out, but it's really serious and when we think about removing obstacles when we're thinking about not only giving everyone the same resources, we're talking about equity based on need. And that's what this picture brings us back to. So we want to circle around this and really center as we talk about preterm birth before jumping in our conversation. So before getting into preterm birth, we're just going to skate over really quick and look at maternal mortality. We know that we're thinking about the family as a whole, right? And so when we're thinking about the family as a whole, we also have to take into account that birthing person or the mother or that woman that's of childbirthing age. So as we're looking at this chart from the CDC, we see from 1987 to 2016 that the numbers of maternal mortality has been steadily increasing in the United States, right? So if we look at 87 all the way up to 2016, we see that climb up. There's a couple of dips in the chart, but we see for the most part, there's a steady up climb. But what's more shocking and alarming is if we look at the right-hand side over here in bold, we see that Black women and birthing people are about 3 to 4 times more likely to die from pregnancy-related complications than their counterparts, and specifically their white counterparts listed. And so once again, we're thinking and circling around equity and racial equity as well. Now we're going to move forward a bit as we think about maternal child health and racial disparities. So we just talked a little bit about that on our last slide. And here are a few facts as we're thinking about from a national standpoint. And so when we look at the US from a whole, if we look at from a lens from racial disparities that impact maternal child health, we know that Black mothers and birthing people are 3 to 4 times more likely to experience preterm birth, so early birth before 37 weeks. And also that Black infants are more likely to be born of a low birth weight. And so thinking about preterm birth, but then also how low birth weight can impact the baby, not only through their time of being an infant, but also throughout their lifespan. We know that there are certain complications that can also arise when babies are born at a lower birth weight. And then Black women and birthing people are more likely to lose a baby to stillbirth than their counterparts. Hispanic or Latinx mothers and Black mothers and birthing people are twice as likely to experience infant mortality in the US. And we know that when we look at through all races, through all ethnicities, that the CDC states that 60% of pregnancy-related deaths are 60% preventable for all folks, all people of any color. And so when we think about the top 4 facts or statistics, and then look at our last one and compare it, we wonder, why does this happen and why is it being? We know that one of our main themes that we'll talk about today is racism. We'll also talk about, mistreatment and also how that plays a part. But we know that there's differences as we look at racial disparity, and we want to make things as better we can and best as we can and improve that for women of color and birthing people of color, but all births and all pregnancies across the board. Now, looking at New Jersey versus the United States, we're looking at maternal mortality rates, and this is 2018, so not too long ago. And as we can see from New Jersey in the year of 2018, that there are about 17.4 births, or excuse me, maternal mortality as we're looking at maternal deaths for each 100,000 births. And as we look at New Jersey, we see that number is going up about a third compared to the United States. And so we're looking at lowering maternal mortality, but we'll also talk about prematurity in just a moment and get into our topic of today. So going right into that segue, we're going to talk right about preterm birth. And so the prevalence of preterm birth, and we're going to take it back to New Jersey as we go into our context of today. Once again, looking at the year 2018. In 2018, there were about 9,601 babies that were born preterm in the state. And so that reflects as about 9.8% of live births, okay? But in 2018, about 1 in 11 babies were born preterm in New Jersey. And as I said at the top of the presentation, data has changed a little bit, whereas we're about 1 in 10 babies are born preterm. And so when we look at the racial disparity amongst, we see that Black infants are nearly twice as likely to be born preterm than their white counterparts. And as we look right over here to the charts, As we see in the blue bar at our right-hand side, we see this played out here in our chart, whereas we have the larger number of babies that are born preterm. And once again, just going back to my original statement, we know that babies that are born preterm are more likely to experience infant mortality or infant dying before his or her first birthday. And so that's one of our main reasons and drivers for really having a really close scope on preterm birth and tuning into how we can make things better and improve for moms and birthing people. Now, as we look at data that's a bit more recent, we see in 2020, this is a reflection of preterm births. And so looking at the state map at first, and I want you all to take a moment to look and identify your county as it relates to preterm birth. And I'll tell you a little bit of a backstory behind this map. So for the Prematurity Prevention Initiative, our first two original counties of focus were those who had the highest rates of preterm birth. And as you can see, if we break it out by municipality, that Atlantic City and Newark are here with a star on the map as higher rates, as you can see, of preterm birth. So if we look at the statewide percentage in 2020, we see that's 9.3%. But then as we get to the darker colors on this key, we notice that those are the higher counties or higher municipalities or cities that have those rates of preterm birth that are larger than their other state counterparts or county counterparts. Now, what I'll also note is that if we look at it through the lens of a county, and then go to the municipality, we see for the state, it's 9.3%. But for example, if we take it from Atlantic counties, we see that it's 9.5 for the county. And as we look once again for the municipality, it's 14.5. And those numbers grow as we think about the racial disparities that we were discussing earlier. And if anyone needs any information for the county, we would be happy to provide this information for your county as well, if you don't see it broken out for you. So let's get into preterm birth risk factors. So there are several risk factors associated with preterm birth. And one thing that's really important to note is that a lot of things could be done. There could be the right type of activities and the right type of exercise and the right type of nutrition and the right type of care throughout the whole pregnancy, and preterm birth can still happen. But we know that there are some preventable risk factors that can certainly impact pregnancy. And so the first one that we have listed here is a short time in between pregnancies. And so we know that it's important to utilize birth spacing. So waiting at least about 18 months in between pregnancies or more can help to decrease the risk of preterm birth. There's also that maternal history. So thinking about preterm birth delivery. So for example, if there's a past preterm birth delivery for that patient, we know that there's a likelihood that there might be a preterm birth again, according to research. Pregnancy complications. So if that patient has vaginal bleeding or a short cervix, multiple pregnancies. So if she's born with twins or has twins or triplets, we know that those pregnancy type of complications or considerations may make that birthing person more at risk for preterm birth. We also say stress during pregnancy. And I would also like to say not only during the pregnancy period, but leading up to pregnancy or throughout the lifespan. We have racism, we have weathering as examples. And if you're familiar with weathering as it relates to Black people, as it also relates to people of color, that's that racism throughout the whole lifespan that especially women of color tend to carry on their backs. So it's all of these types of discriminations and all these types of obstacles that people of color go through. And because of this type of stress that is endured, and as we say, like an allostatic load, because of that, we know that that stress can lead to preterm birth as well. Then there's also latent absence of prenatal care. We know that according to studies that can increase the risk of preterm birth. And then lastly, different lifestyle factors. So the pre-pregnancy weight, about being obese, or if there's underweight, that can increase preterm birth. Alcohol or substance misuse, can also increase the chances of preterm births. So we know that there are a lot of obstacles here. There are a lot of risk factors. And so we're here to help and to educate, as well as to form those strategies to move forward. So preterm birth prevention and intervention. So we talked about risk factors. Now we're going to dig into the prevention and the intervention side. So on the prevention side, as I mentioned on our last slide, the very first thing that we talked about was birth spacing. So we know recommending birth spacing, according to the CDC, at least 18 months in between pregnancies is known to reduce the risk of preterm birth. Also seeking prenatal care that's early. And one other thing that we like to note is before prenatal care even happens, having conversations about pregnancy and our preconception care is extremely important when it comes to preterm birth. We see better outcomes in that avenue, as well as lifestyle changes. So you may see for PPI in the past, we have had pregnancy types of forums and different conversations, but we also like to weave in conversations around nutrition, around stress reduction and exercise, and note how important all of those facets are as it relates to prematurity. Now, what we'll do for the next few slides is that we'll look into the pieces of intervention. So as healthcare providers, as clinicians and practitioners, these are really three powerful interventions that you can walk away with. I'm sure a lot of you are already using these interventions, and we love to hear from you of how they're working for you and your clients. But today we'll talk about 17P, vaginal progesterone, as well as cerclage. So we're going to walk away with those three interventions. So starting off, what is 17P? So if this is your first time hearing 17P, we'll take a pit stop and actually define it and go backwards a little bit and talk about it for a second. So 17P is a medication that helps to prevent preterm birth. And so the breakdown of this name, and a lot of us know it as McKenna, but the longer name, or that name that is given, is the hydroprogesterone capitate injection. This is a weekly injection that birthing people receive. And to receive this medication is for patients who have had a previous preterm birth, so those who have had that experience in the past of a previous preterm birth or spontaneous birth, and those who are currently pregnant with just one baby. So this medication would not be for someone who's pregnant with twins or triplets or multiples, right? I did miss our point in the middle that progesterone is a hormone. It helps to help the uterus grow. So we already have progesterone naturally occurring in our bodies, but this is a additive that we sometimes women and birthing people need to help to keep from having contractions during pregnancy. And so as per 17P administration and benefits, so how is it administered? 17P, as I mentioned, is given on a weekly basis. We started about the 16 to 21 week mark, and those injections are given all the way up into the 37th week of pregnancy, or if the baby is delivered before the 37th week, then those injections would of course stop. There's two different options for the injection. So there's one that's that generic, that regular injection, but then there's also a auto injector as well. Now, one of the big benefits behind 17P, we know that it has the potential to reduce the risk of preterm birth and birthing people. And once again, we know that these are birthing people that have had one previous preterm birth, and number two, that are not pregnant with multiples. So very great tool and research behind it that backs that 17P has a possibility to reduce preterm birth. And then next intervention that we'll discuss is a cervical cerclage, which is also a cervical stitch. And so with the cervical stitch, it's a surgical procedure. This is done at the 12th or 14th week of pregnancy, and it involves that closure of the cervix. And so we know with studies, we know with research that the patients that receive the surgery or cerclage, if they have impotent cervix, or if they have a short cervix, that this can help to prevent a preterm labor or spontaneous birth. And in a study that the American Pregnancy Journal shared, we saw that it's about 85 to 95% efficient when we think about the effectiveness, which I think is great to note. The last intervention that we'll discuss is vaginal progesterone. And vaginal progesterone, we know, is very similar. If you're watching the words, if you're unfamiliar with the terminology, you're not one of our providers here today. Progesterone, as we saw with 17P, is carrying that same example, only that 17P and progesterone are different because 17P is an injection, whereas progesterone you would actually put on this vaginal cream. So with this vaginal cream, the progesterone can help to reduce the risk of preterm birth in patients if you have the associated risk. And we know it's also a hormone that helps the uterus stop with the contractions, very much so the same as 17P, but once again, does not have the injections. It would be implied to the vagina multiple times throughout the day. So we're going to move from the interventions, but we're looking forward to diving back into that just in a moment because I want to share that 17P is available through PPI, and we do have funding to support that for any provider who may need that for their patient, but we'll get back there in a moment. But we will share a few goals of the Prematurity Prevention Initiative. And before I get into the goals, we love to highlight some of our pictures throughout the years. I'll start at the top right-hand corner, and I do have my team member on here, and this is when we had a presentation for nurses in North Jersey. We talked about preterm birth, as well as some of the topics that we're discussing now. In the middle, we have Dr. Ruffin, and she is the medical director of the Southern Jersey Family Medical Center and OBGYN, and a wonderful provider and great speaker as it relates to preterm birth. And then as we look to the left-hand side or going around clockwise, we see that this is a picture of the NAACP, Black Infant and Maternal Mortality Task Force of Atlantic City. And so PPI teamed up with the NAACP throughout the state of New Jersey to create these task force. And I would love to tell you also how you can get involved if you would like to join a part of one of our task force throughout the state. So in the interest of strategies, PPI crowds around a few different strategies, and the first is engagement. So we're looking to engage all throughout different avenues. It might be in webinars such as this, but also from a media side, from social media, from toolkits to newsletters to in-person engagement. You'll see us in all different types of avenues and spaces. We're also looking to create awareness. So for provider communities, as well as parents and our communities at large. Collaboration. So PPI has its own clinical leadership team. And on that leadership team, we have OBGYNs, we have maternal fetal medicine specialists, doulas, and midwives that contribute to the team. And so we are really housed and really upholded to collaboration throughout our project. Education, which we'll talk highly about today in a few slides. And then lastly, our resources, which we have for providers, as well as our patient and parent community. So speaking to the resources, we'll talk in the next few slides about what type of resources that PPI has to offer. First, we'll talk about 17P and the virtual coach tool. We'll also mention about supporting NICU parents. So those impacted by early births or those who have children in the NICU, what type of support do we offer? We have self-management tools for those who are in their prenatal and their postpartum stage. And then lastly, always education for everyone. So we'll talk about those pieces as well. So for 17P, so PPI has funding to support those who are in need of the medication 17P. And we know that 17P is given at a sensitive time between that 16 to 21 week. And so for those who are in need of those injections and need them during that time, and might be a time crunch, I know sometimes it is, PPI has that available. So we do have it here. You can access that funding or that grant that we have through our website at njpreterm.org/providers. And not only do we have the funding for the medication 17P, as I mentioned in our slides, we know it's given on a weekly basis. And so PPI also does have a home visiting nurse program. So if there is a need for nurses to come out to your patients' homes, we also do have that resource available as well for free under our grant. We also like to mention that if there are any barriers transportation-wise, we also like to highlight what the First Lady of Nurture New Jersey First Lady Tammy Murphy has in place, which is a partnership with the NJ Access Link. And so that's a very valuable resource as it relates to transportation as well. The last piece I want to share on the slide is the virtual coach tool. So we know if birthing people are taking the 17P shots or having them administered on a weekly basis, that sometimes we're thinking about motivation and retention as it relates to the 17P on a weekly. And so we do have a virtual coach tool that go right alongside 17P. So if any of your patients are taking 17P and would like that encouragement on a weekly basis, that type of motivation, as well as what type of exercises can they do while they're pregnant, what type of great food can they eat, I highly recommend the virtual coach tool, and we could share some information on that as we close out as well. Another resource under PPI's umbrella is presentations. So very similar to what you're hearing now, we have presentations for patients, for community providers, medical professionals as yourselves. And I also like to mention that this year that we launched a archive. So if you have missed some of our really great presentations, one being by Dr. Joy Career-Perry that we had last year on advancing birth justice under PPI. And I mentioned Dr. Ruffin earlier, and here's a video from her on preterm birth. We have a whole library of resources at njpreterm.org/videos. So speaking of trainings, so we have a Power of Our Voices training. And so Power of Our Voices is a 2-day training. It is free. And originally we created this training in mind, thinking about community members, those in faith-based organizations and sororities, fraternities, all types of community members, particularly in Black and Brown communities, and thinking about how we can have conversations about Black maternal health, infant mortality, maternal mortality, preterm birth, and improving these circumstances around birth outcome and pregnancy outcomes. And so this 2-day training, it goes into all those maternal child health features, as well as it talks about the history of childbirth in the United States. So what type of injustices have happened in the United States, and how can we overcome, and strategies to move forward. So we have this training on a quarterly basis, so do look out for the next training in the fall. And once again, this is a free training. We do offer a certificate after completion. And I think it's a really great 2 days for those who have taken it, and for those who want to move forward with it as well. All right, so PPI also offers free education materials. So we have information with diabetes, hypertension, as well as preeclampsia, knowing the signs of preeclampsia for your patients and for your clients. And in the middle, we have our Navigating the NICU booklet, which I'll talk to in a minute. That's a wonderful booklet for those NICU parents who might need help to literally navigate the NICU and to know what type of questions to ask, to really have that support and backing. But we do have these resources available. So if you just send me an email, we will shoot all this information to you. And once again, our website is really a great hub for all these resources. So anything that you would need to download, we have the resources, as well as our newsletter and toolkits, which I'll talk about in a moment. So speaking of our newsletter, we have a quarterly newsletter, and this is made specifically for provider audiences. So it has timely information and resources, as well as data to back up any information that you may need or want to share with your colleagues. So I do suggest that if you have a moment in your time to download or to file for Right on Time, and to get that newsletter in your feed. I also do recommend on social media. So we are all throughout the social media verse, if that's a word, but we are in Facebook, Twitter, Instagram, but I really mention for professionals and providers that we have LinkedIn. And so from that type of LinkedIn aspect, we have articles that we generate, such as on Black maternal health and prematurity, trainings that you'll find that are really relevant and, once again, timely. So a few other resources to share. This is our social media toolkit. This is Watch Me Blossom. It takes 39 weeks to grow. As we're talking about social media and really thinking about preterm birth and how we can develop messages around that, this toolkit was provided by our team to mobilize families, but then also providers. And as you see on our next page, we have a sample list of our toolkit. So this is what providers may see: reduce unconscious bias and how to impact birth outcomes in a positive way. We have The sample posts are already created, and all you have to do is download this free toolkit, and you'll have all this information at your fingertips. I also want to mention the maternal experience survey. And so from the stance of patient as well as providers, we know that historically that Black women and women of color, that there have been mistreatment, that there has been a lot of different types of ways that women were treated as we think about Black and brown women as it relates to their counterparts. And so we're looking for the feedback of Black women as well as all birthing people throughout the state of New Jersey to share how they were treated through their birthing and their pregnancy experience, to share how their support people were treated. We're looking to support hospitals and health systems with this information to provide it back to you all so that we can have a positive feedback, so that we could have all the real feedback and the real stories from women in those experiences to see positive outcomes throughout the whole state. And so for those who complete the survey, it is confidential. We do have it in both English and Spanish available. It is on our website. And for those who do complete the survey, they do receive a gift card while supplies last. So we want to share, we want to have women be heard and also expect change, because we want to focus on bias and different types of obstacles as it relates to health and racial equity, and to make things better at all hospitals, healthcare, and every type of system that's treating women and birthing people. All right, I'm getting down to the end of our resources, and this is one that relates to the top of our conversation. I mentioned about the NICU, right? So we do have PPI NICU kits that are free. And in these NICU kits, they have an insulated bottle cooler bag. So we're thinking about birthing people that are lactating or that are feeding with formula and keeping that cool. We have journal, we have children's book, ice pack, reusable face mask, hand sanitizer, and the list does go on. But one thing I want to reemphasize is that we do have a booklet that we created. It's called Navigating the NICU. It is for NICU parents. And so we do have these free kits available upon request. So you would just go to our website, njpreterm.org/providers, and request those kits. And you could also request the booklets to be sent to you separately as well. All right, so this was also mentioned in your registration today. So we do have self-management tools, and some of you who may be on right now have maybe possibly received the Go kits for your patients in the past. So we do have some kits available. And so we also have, I want to hone in on the self-management tools that we have available in our stock, which are the blood pressure monitors. We have large cups if needed for your patients as well. As we're thinking about hypertension, as we're thinking about preeclampsia, as well as any type of diabetic disorders or diabetic conditions, we do have urine test strips. So I would love to send these out to you if you're in New Jersey. We can certainly send you some kits for your patients. So please just send me an email, and I'll share my email at the end, or I think it's also on the screen where you can request the kits. All right, so summing up our conversation today, I'm just going to throw a couple of actions to take from our points that we made. And first, we're looking to develop a maternal child health practicing guidelines and protocols. So as it relates to health equity, as it relates to racial equity, thinking about what can we do at our practices and in our clinics and in our hospitals that's protocol specific that we can put in place to make birth outcomes better and improved. We also want to educate staff on prematurity prevention, interventions, disparities, and one big notion that I want to get around today is the intervention piece. So 17P, which PPI does have, the cerclage, as well as vaginal progesterone, really taking our time to look and identify what interventions may be great for our patients is something that I really want us to take away with today. As well as promoting implicit bias training in health systems. That's a part of our point number one. We want the practice guidelines and the protocol to really reflect equity and inclusion. And so implicit bias training is a really great step in that direction. As I mentioned, that with early prenatal care, we know that studies show that there can be a decrease in preterm birth. And so thinking about early prenatal care as well as preconception care for our patients and our clients, and referring patients and clients to those resources are really important, extremely important, to critical care for our patients as it relates to preterm birth. So plug here, but share PPI sources. I mentioned so many different services and resources that we have, and we are looking forward to sharing them with you. So please do share them with your patients. And if there's any colleagues that may need them, feel free to pass along the word as well. We also want to talk about advocacy. So advocate for maternal health resources. So if you are at a clinic or if you're at a hospital that is in need of lactation support or midwives or doulas, please continue and look into advocating for those resources. And then lastly, educate community and colleagues on issues that involve Black infant and maternal mortality, as well as prematurity. There's so much to say in these spaces, and the more that we talk about it, we see a lot of change can come from it. So let's continue to keep the conversation going. I thought that was my last point, but I have one more: increase social media outreach. So we shared those toolkits that have those messages that are already pre-made for you. And so we have the toolkits, we have social media posts, all different types of ways that we can interact with patients and our provider community. And so I encourage you to download our free toolkits and any of our resources. Once again, for providers, just a couple of links here. As I mentioned, one of our major links for you will be NJ Preterm/providers as it relates to 17P and our NICU kits. But if you need anything directly, and if you can't find it on our website, feel free to email me at civory@fhi.org. And I just want to say that we all have a role in improving pregnancy and birth outcomes, and I appreciate your time today. But on behalf of Prematurity Prevention Initiative, Deja and myself, we thank you, and we look forward to hearing your questions as well. Thank you.
Perfect. Thanks, Christine, for your presentation. So I'll hop into the Q&A. I have about 3 questions to ask for today. Can 17P help if a birthing individual already has a pre-existing health condition? So is there any impact with that on someone who already has a pre-existing health condition?
Yeah, some really good questions there. So as far as I'm concerned with studies of 17P, if someone already has a pre-existing condition, such as we talked about chronic conditions today, such as diabetes or hypertension, I don't see anything research-wise or research-based that would disqualify someone from using 17P. So from what I see all across the board, just as long as it is a birthing person who is not pregnant with multiples and also has a pregnancy experience or a previous preterm birth experience, I should say, those are the qualifications, but nothing else would be a deterrent from what I could see research-wise.
Okay, perfect. Next question. Has there been any clients who have used 17P, and what was their success with their birthing outcomes?
Yeah, that's a wonderful question. And that's something that I would probably turn back to some of our providers that are here on the line today. I'm a public health professional practitioner, but if there's anyone who has patients that have used 17P, I want you to chime in the chat. Let us know how it went. We know that there's a likelihood of that risk being lowered. So that's a question I want to throw back to those who attended today. It's a good question, though.
Mm-hmm. So while we wait, I'll ask our next one. Can you share how 17P cerclage and vaginal progesterone may differ when it comes to a birthing individual's experience?
Yeah, definitely. So for 17P, we know that there are different entry points for each of the medications, right? So for 17P, we know, I'm not trying to be like a broken record, but we know for 17P, that is for someone that has experienced a preterm birth before. So someone who has had a spontaneous or preterm birth in their history, and they cannot be pregnant with multiples to take the medication. We know that with the other two interventions that we talked about, cerclage and progesterone or vaginal progesterone, is a little bit different. The qualifications of the same things I mentioned are not the same. It's a little bit more freedom. But as far as our entry points of the time of which we can, start the medication for 17P, we're usually around the 16 to 20 or 21st week that we can take or start or initiate 17P. About the 16th week for vaginal progesterone, if I'm not mistaken. And then for cervical cyclage, I think it could be a little bit later in the pregnancy. So it's just, we have to look at the guidelines around our entry points, if you will.
Perfect. All right, so I don't see anything coming into our chat. If anyone has any questions and may want to come off mute or share any, if there was any success with their clients who may have used 17P, this would be the time. You want to come off mute now or share in the chat?
Absolutely. We'd love to hear your questions, any way that we could support you, and just any experience around preterm birth that you might want to share to this group would be really helpful for our conversation if you'd like to.
Excellent.
All right.
Okay.
Thank you,
All right.
Emily.
So I'll say our closing remarks. So thank you all for joining us this afternoon. We hope you were able to take away some great information from today's presentation. Oh, I see a chat from Ashley. So she says, we've had success in our OB practice with 17P. We have about 3 patients currently using the injections. Great.
Thank you. It's great to hear that from a provider standpoint. As I mentioned, we're not providers, so we know that we gathered providers today. So any perspectives that we can gather from you is super important for us. So thank you for sharing that, Ashley.
Thank you. Thank you, Maria, for your message as well. All right. So once again, thank you all for joining us this afternoon. We hope you were able to take away some great information from today's presentation. After today's presentation, just be on the lookout for a follow-up email. We will be including an evaluation for today's event. Next Tuesday, we hope you are able to join us for our second summer speaker series event. So next Tuesday, August 30th, we will be hosting a panel conversation called Breastfeeding 101. And through this event, we will have an open panel conversation to honor Black Breastfeeding Week. This discussion will highlight the essential role of partners and family members, available support for NICU families, WIC resources, and more. So we really encourage you to share this with your fellow colleagues and the families you serve. Like Christine mentioned, our social media handles, but you can also still follow us at NJ Preterm on social media to stay up to date on any upcoming PPI events we will be hosting. Additionally, in the chat, I did send links for our link tree, which provide resources for PPI as well. And I'll include both myself and Christine's email if you have any additional questions for what you heard today during our presentation or anything revolving around PPI. So let me add that now.
And lastly, I'll also add, I know that we had our registration, and for those who are interested in receiving those blood pressure monitors and the urine test strips for their patients, we'll be in touch with you just to get a number on how many you would like. We have plenty to share with you and your patients, and so we would love to share that out with you as we think about self-management and how that can definitely help patients during this time.
Great. So I think we have about 10 more minutes, but if anyone wants to come off mute, share anything, any last final remarks.
All right, with none heard, we'll close it out. This is recorded, so we will send it back to you just if you'd like to share it with a colleague or review it again, but we will be in touch about any resources that we shared out today. And thank you all so much, and we'll see you next week for Black Breastfeeding 101 to carry on that conversation.
Thank you, everyone. Have a great rest of the day.
Thank you.